I'll try to speak slowly because I know it's a challenge for interpreters, but you tell me if I'm not loud enough or I'm going too fast. I'm from New York City and we speak very fast, so I apologize. Also, my colleagues, Dr. Glasser and Dr. Blumenthal, have been some of my role models, and they have had vast experience on the subject that we're going to be discussing now. This is very important to us because there's been a real movement of thinkers in medical education, not just on the quality of the doctors we produce, but what is the impact of those doctors on the health of the communities they serve? And what is the impact of the academic health centers in local health? And I know that that's sometimes difficult because the academic centers don't control the health delivery system. But we have to find a way to link with that system, and that's some of what I'll talk about. Also, I'll talk about the experience of a group of schools in North America that have gotten together to try to push this agenda of what is the relevance to our social mission and to measurable improvement in the health of our communities. This is very, it kind of brings me back many years because 35 years ago, the World Health Organization in PAHO set up the Network for Community-Oriented Medical Schools, and all of us have been members of that. And this is going a step further. The network is having its annual meeting here in Fortaleza in 2 months, in November. So this is timely. Also, I learned a lot from colleagues in Brazil, and I think I'll present that tomorrow, but one of them was from Londrina, learning about community health workers, and the other was from our colleagues from Roraima. I think it was there about 5 years ago, and we had an exchange in how we also train and deploy indigenous health workers. So there's been a very good exchange of learning from each other. So today, I would like to touch on these areas, kind of the global view of why the changes are critical and necessary, and what are really the underlying causes of ill health that must be addressed, and they involve all of us. There's nothing special about the United States or Brazil. We're in a global economy with global problems and challenges. Then I'll talk about how we got to the model of medical education we currently have, and what are some of the failings of that model, and then finally some examples from the various medical schools that are trying to make bigger changes in North America. This is Bly's concept of, it's just one example of the haves and the have-nots. And if you look at the OECD countries, the North America, Western Europe, Australia, they have, though only 15% of the world's population, they consume 75% of the resources and income of the whole world. And that disparity says a lot because it means that we deprive other parts of the world that are called peripheral from access to those. It distorts the ability to improve health. It fosters migration, legal and illegal, brain drain. It locks poorer people into where they are. There is a myth of picking yourself up by the bootstraps and making a greater income. Most people don't. They're locked where they are. And that creates a terrible ill health and massive disparities. This is just an example. If you look at different countries, this is the Gini index, which says to what degree is there inequality in income. So the higher you are, the worse the inequality. The lower you are, the less the inequality. Worst inequality, better. And as you can see, if you look, oh, I have a pointer here. Oops, you have to be very good at this. If you look at Brazil, China, United States, India, all of us are getting more unequal, more inequality. The median income is going up, but that's because a smaller number are very rich and the others are staying flat or going down. So the disparity is higher. And disparity in income is one of the largest drivers of ill health in the world, of all countries. It's not just in the Western, North American, Western Europe countries that this disparity occurs. If you look at the cities in the United States, every one of them has pockets of such extreme disparity in income and health and access that you could, this is just one example. If you look at some of the inner cities in these countries, really, they're doing about the same in terms of health and longevity as developing countries. There's really no difference. And that's what all of us see all the time. And why is this important? Because the world is becoming more urban. Even rural societies, even a state like New Mexico, people are becoming urban. It's flooding the urban environment. And this is becoming a health problem because the disparity between rural and urban areas is so severe that we cannot stop the rapid influx of rural populations into cities. But the cities are not prepared to expand to accept them. So you create another disparity of people living in the marginal areas of cities or in underserved inner city areas. And you have awful disparities in terms of housing, for which poor people are not prepared. In some of the towns in New Mexico, as oil and gas become a larger and larger part of the economy and wealthier people move in, they take up the housing that poor people had and they fix that housing and they push poor people out. So housing then becomes one of the biggest health problems as a social determinant. So how did this all begin? Where in North America, we have a model of care that was thought to be the best in the world. It made us very scientific. And Abraham Flexner back in 1910 evaluated all the medical schools in the United States and Canada. I don't know how he did it. There's over 100 and some odd schools, but he visited every one. And basically he said, they're just churning out doctors of very poor quality. They did not have a scientific base. And he recommended that they close half of them and they cut the number of students way down. And that they have to really, to be scientific, link with universities. Those are the big changes. What people didn't realize is there was a downside to this. They closed most of the women's medical colleges, the black medical colleges. The social mission of medical schools almost disappeared, and it was all biomedical. So that's a very important legacy, which we don't think about, but we live with it today. The other is that over the last century, sorry.
You're asking me if you can speak a little bit.
Oh, slower. Oh. I was very slow for a New Yorker. This is terrible. Maybe a Texan would talk slower. What has happened is there's been a large increase in funding of medical schools by the federal government for research, for advancements, paying for residents. But when you have a model that's so driven by research and sub-specialization that it distorts who you train, where you train them, and how you train them. So we have way too many specialists compared to primary care. They train almost exclusively in big city teaching hospitals, which are disconnected from where people receive their care, become ill and well. And it is almost the teaching hospital and the different departments in the medical school that determine what kind of doctors are going to be produced. And they want to produce doctors like themselves, totally disconnected from what kinds of doctors society needs. There's no transparency, no one stops them until Obamacare, the Affordable Care Act, is calling into question this unbridled growth which has not served our country that well. And as a result, the image of our medical colleges is often in the public mind very much formed by newspaper or magazines like U.S. News and World Report, which rank all the schools. And what do they rank them on? They rank them on research dollars, reputation, test scores of students, the very things that have virtually nothing to do with the health of our population. But that is what has driven schools to keep perpetuating the same standards, lunging after the same goals. So, we think we are failing. One of the big disparities in the United States and somewhat in Canada between the students we're producing and the society that needs them is the student's family income, which is very, very high and getting higher. So the wealthier the students, the less likely they are when they graduate to serve an underserved or poorer population. The percentage of ethnic minority students in the United States is increasing, but very slowly. But the population is rapidly becoming more and more ethnic minority, Hispanic, African American, indigenous. So that in the next 20 to 30 years, the majority of the population will be ethnic minority in the United States. What does that mean? In recent studies, if you are Hispanic or an African American doctor, your likelihood of seeing a patient of that ethnicity is 5 times as high as if you are an Anglo white doctor. So in a country that is rapidly becoming diverse, we are not keeping up, and we're making a barrier to access to care because of these policies. As I've mentioned, the huge dollars that come for certain kinds of research, and by the way, it's research that is not necessarily driven by what community priorities are. For example, I'll give our own state in New Mexico. The research priorities of our university are brain and behavior, cardiovascular disease, and cancer. The priority problems from all the communities in New Mexico are first, alcohol and substance abuse, second, teen pregnancy, third, violence, fourth, access to care. There's no connection between what communities need and what we are researching. So we have to make that bridge. This is a map in the United States linking 2 important factors. One, the highest mortality is in the south, you got to be really good at this, is in the southeastern part of the United States. Highest mortality, highest obesity, poorest control of diabetes, and social factors. Lowest graduation rate from high school. So there's an a connection between low educational attainment and all of these chronic diseases. So this is an internal, within the United States, horrible disparity. If you look in each city, you will find enormous disparities in health and longevity, lifespan, even within neighborhoods next to each other. So this is an example in New Orleans, where you have a wealthier community, looks something like Japan. The longevity is on the average 80 years from birth, as opposed to inner city African-American community. This was the area actually was flooded, 55 years from birth. So look at that enormous disparity within our own country. So Fitzmullen, Kellogg Foundation money, George Washington University, and others pulled together, very much like the network, but within North America, 6 schools that seemed to be breaking out of this pattern, that wanted to continue their social mission and to promote that. And we have amongst us several of the schools represented here, that including Morehouse Medical School, University of New Mexico. I don't know if he's coming from Northern Ontario. Yeah. So I have half of those schools are here. And they conform to what populations need. They want their next generation of physicians to, they want their medical schools to educate physicians. They want them to care for poor people, solve pressing complex problems. But as opposed to that U.S. News and World Report ranking every year that comes out, and every school looks to see if it's high on the list of the top medical schools. And remember, that's all research grants, test scores, all of that. What Fitzmullen did with his colleagues is they did a better ranking. They looked at schools in terms of how well they serve society. And they had, how many primary care doctors did they graduate? Were those doctor graduates practicing in underserved areas? Were the students from underserved areas? Were they from ethnic minorities? And so when you looked at all these patterns, they came up with a radically different ranking, which happened to be almost exactly the opposite of U.S. News and World Report. The top school was actually Dr. Blumenthal's school, Morehouse Medical School. University of New Mexico just got in the top 20, so thank God. But there was something else this showed. Most of these schools, are public schools, and they're schools that have a focus on minority students. Most of the low-ranked schools, these are the lowest in the whole country, there's 130 medical schools, so these are the bottom 20, are private schools that have less contact with their community, and they are high research schools. And it doesn't make sense that research would draw you away from concerns unless you didn't listen to what the concerns were that drove your research. So this was an important study. And how did the medical establishment in the United States respond? They hated it. They tried to kill it. They didn't want it to see the light of day. But we're here now, yeah. So what they did, that is the same group who just did that study with their Kellogg funding, is they identified these 6 schools, Oklahoma, Morehouse, Southern Illinois, University of New Mexico, A.T. Still, which is an osteopathic school, and then Northern Ontario. And they felt that those schools had so much to teach others because they were trying to make a difference in every aspect of education, research, service. So that's what I'll present very quickly. This is the location of the schools. These schools had a very explicit mission statement. Now, most missions just gather dust and no one can remember what they were. But these were very tied and they're very public. You know, whether it was we're going to serve the underserved in a community or we're going to measurably improve the health of our state, the mission in these schools meant something. These 6 schools all invested heavily in kids from middle and high school to get them prepared to go to health science schools, nurses, doctors, pharmacists, because the problem doesn't start in medical school. It starts with children in underserved areas or rural areas or urban underserved areas where the education is very poor. And if the education is poor, the test scores are low and they don't look as good on an interview. Often in our state, they have to work on the farm. They don't have extra money to work with Sister Mother Teresa in India, right? They don't look as good on it. So we made these changes were important. The admissions policies had to change so they were not so heavily influenced by test scores, but brought other factors that are more closely linked to serving populations. The curriculum, as you all know, changed rather radically, and it wasn't just the problem-based learning from years past. These were all innovations in curriculum, including integrating public health in all the education, lots of primary care exposure. In most schools, there was a heavy emphasis in students being out in communities for long periods of time where the different role modeling took place, serving indigenous people or migrants, other communities at risk. And there were very strong mentoring. There was also, as I had mentioned before, each of these schools has a strong commitment to the health of their geographic area served. We have some big, famous private universities in New Mexico, in the United States, that have a bigger investment in international health than they do in the health of their own communities. And that has to change, because even private schools, most of their money comes from public dollars, but they don't necessarily respond. Each of the schools looks at the relative health of communities served, and these two simply look at measuring the health of local counties where they live. This would be kind of the bottom, where most of the factors, access, prevention, primary care, are very low. So you measure what has to be changed and then say, have we done anything about it? So these schools took this seriously. Rather than, we're going to train a great doctor, and when they graduate, goodbye, have a good life. Each school produced outcomes. These are just some. For example, New Mexico, our programs of pipeline and admissions makes us now, the student body is exactly reflective of the state in terms of ethnicity. So 53% of the students are ethnic minority. Huge change over the last 10 years. In Northern Ontario, the highest rate of keeping their graduates in Northern Ontario and going into primary care. Their rate is about twice the percentage of other schools in Canada. In Morehouse, even though they have taken a higher risk student body in terms of test scores, the quality of their education means they pass their boards at a very high rate. Southern Illinois, very high percentage of graduates in underserved, and I'm going to show you some of the slides from the University of Oklahoma. Now, the Flexner, that group of 6 schools, then also had strategies for working with very stressed communities, communities of high socioeconomic disparity, poor health, and the term it's used in the United States is hotspotting, where you take in any community very high-risk group, and you really focus on that group to improve the health of the whole community. And the reason is, in any population, the top 5% of users of that system consume 50% of the resources of that whole health system. 5% consume 50%. If you can focus on that 5%, you could save resources. So these are some examples. In the University of Oklahoma, it's a very urban focus. Tulsa is the city they live in. They were able to draw maps that showed that where the highest needs were exactly opposite to where all the doctors were. And that meant the access to care was very poor. So in terms of their approach, they had to find ways of bringing care to where people lived and not sitting where they're comfortable at. If you look at another community in New Jersey, their hotspotter issue was looking at where people come from who visit the emergency rooms for problems that should have been prevented had they had good primary care. Asthma, diabetic ketoacidosis, all those acute conditions that if you have good care, you shouldn't be in the emergency room. And they were able to find these neighborhoods and then intervene with special teams to get people connected to primary care to show an improvement. Well, what the University of Oklahoma did is they decided they wanted their medical school to really be a public service, a public city utility for that whole city. And to do it, they could not do it alone. They had to work with partners. And those partners were necessary if you're going to address not just the biomedical problems, but social determinants, education, food, transportation, all of those issues that have a much greater impact on health than health services itself. And these are just some examples. For example, they found that in poorer communities, the number of people who had legal problems, threatened being kicked out of their homes, or child care disputes with an abusive spouse, all of those issues could be better handled if they had legal advice in their clinics. A very large percentage of patients simply didn't know how to navigate in their very complex health system. So they had librarians working on what we call health literacy, learning how to use the system. They had two other hot spots. One of them was opiate abuse, and unfortunately in the United States, we have a huge opiate addiction. But part of that is that we also have the highest rate and absolute number of people, mostly of color, in prison and jails. Huge population, much more than China. So that this becomes a terrible cycle, because once you're arrested, it's very hard to get a job, and then you're in the criminal system, you're marginalized. So they put their emphasis on kids who are having difficulty, foster kids, opiate addiction. All of those programs had this dramatic effect. One, much lower rate of people going to the hospital, and look at this, lower rates of people going to jail by social interventions. Incredible. They also discovered that there was very poor communication between hospitals, specialists, primary care, community agencies. So they put together a very extensive electronic communication and referral system, which is a real model. This is the data that's so important as to why social determinants must be addressed if our goal is to improve health. And that is this sad fact that the healthcare system only affects about 10% of what makes us healthy. Only 10%. 50% are these lifestyle issues, which have a lot to do with health disparities, smoking, obesity, stress, nutrition. And about 20% is environment, pollution, other stressors. This is simply showing the relationship between income and health. In virtually every chronic disease and every risk, you can see that the higher the income, the lower the rate. This is one of the underlying causes that are more recently described, which are the adverse childhood experiences. And what this data showed was that if you looked at 7 factors that occur in childhood, if you were physically, sexually, or emotionally abused, if your mother was beaten, if someone adult in your family was in prison, adult in your family had alcohol or substance abuse, or was addicted. Those factors, as you add up more and more factors, every single chronic disease is more common when you become an adult. What a finding. These are social impacts on medical conditions. And this is the theory behind it. In the bottom is just the neurodevelopment of the brain in childhood. But what they found is that if you are under high stress when you're growing up, your brain is kind of wired so that you seek soothing and protective activities and comforting behaviors very quickly. There's no delay in seeking that, whether it's eating, whether it's looking for love in all the wrong places through sexuality, whether it's being accepted by peers by doing dangerous things. No teenager is going to want to say no when they're invited into a group and not participate. They'll do almost anything to be accepted. It's a fate worse than death to be socially excluded. So all of those are what lead to these risks, and that leads to chronic disease. So it's another way of saying our social environment is what drives our physical health. And our medical schools have to become engaged in this. In Oklahoma, what they discovered, there are different kinds of funding sources for this. Others outside that have a lot of money that want to give for social good, but it has a health impact. So what they've done is connect with United Way International. And they've even gone so far as to tap into wealthy donors. But the reason is, they said, if you have a healthy society, it's good for the wealthy as well, rather than separating a zero-sum game, where if you give something to the poor, it takes it away from the rich. They've found ways of saying it's all connected. So thank you.